Understanding dermatomes is an important part of orthopedics and neurology. And lest people think I have made up the idea of dermatomes, I want to assure you that these are well-established principles. I use this poster in my office if I want to demonstrate to patients what dermatomes are. They are areas of skin in the body that are innervated by a very specific spinal nerve root. And in the spine, we differentiate 4 sections: cervical or neck, thoracic, lumbar or low back, and sacral. And we use letters to designate each part, and then we also have numbers that identify which spinal nerve root it is. So it could be C3 or T7 or L5. And each of those specific spinal nerve roots, the nerves that exit the spine at that level of the vertebral bodies, they correspond to a different part of skin. And these are different than the peripheral nerves, which are highlighted on the other side of the body in this diagram, which have patterns that overlap, but also are different in terms of the amount or the area of skin that they innervate. This is so important in orthopedics because nerve root irritation at the level of the spinal nerves can create symptoms not only locally, but also in the limbs. And that's why understanding this map of where C3 innervates, where T7 innervates, where L4 innervates can help us understand what the diagnosis may be. Pain can be a common symptom reported, but numbness and tingling, paresthesias, other kind of less common symptoms are also reported. How this really applies to my work is that if a patient presents with a limb symptom, so arm or leg complaints, I must, as a possibility, entertain the idea that the problem in the thigh or the forearm is actually coming from a spinal nerve root irritation, and that symptoms felt there are actually referred from this nerve root. They are not local. They are not due to a problem in the thigh itself or in the forearm itself per se. I don't think many clinicians are really taking all these dermatomes, this map that we learned in school, and applying it to their practice for various reasons. I think if patients report numbness or tingling, it's more likely that clinicians are considering spinal nerve root irritation. And people may not use the word irritation. They may use pinching, or they may just call it a disc herniation that is affecting the nerve. But I think a general term of something being problematic or irritated at that level of the spinal nerve root is kind of a nice term that encapsulates lots of different ideas. And it's not that important to be more specific with the terminology in my book. So I think numbness and tingling is more on people's radars, and bilaterally, I think it's more on people's radars as well. For example, if someone presents with bilateral hand pain, I think the clinician might be more prone to considering a problem in the lower neck or upper thoracic spine. But in my experience, especially if the symptom is pain or tightness or achiness, and especially if the pain is unilateral and below the knee, I find clinicians are not considering that the problem is not local. They're not considering that the problem is actually in the spine. So, for example, if someone presents with right calf soreness or just left foot kind of tightness and achiness, they're not considering, oh, it could be something from the lower lumbar region. Now, the good news is a lot of these spinal nerve root irritations, I find the majority, are irritations that can be reversed by moving the spine in a specific direction. For example, cervical retraction or thoracic right rotation or lumbar extension. And I approach these problems by doing repeated movement testing to figure out if the problem is a mechanical problem that can be reversed with specific movements done repeatedly or not. There are definitely some cases where inflammation is what's irritating the spinal nerve root. There are definitely cases where something structural is irritating the spinal nerve root. But I do find that the vast majority of these problems, when they're presenting with irritation of the spinal nerve root, can be reversed with very specific movements. And I call those mechanical joint derangements using the nomenclature that Robin McKenzie identified. But we need to have on our radar, especially in the absence of an acute problem in the limb, that limb symptoms or chest symptoms, for example, when we talk about the thoracic spine, and head symptoms when we talk about the neck, we need to consider that these problems that are away from the spine itself could be due to spinal nerve root problems. You can obviously buy posters like this, but if you just do a quick Google search, what is the dermatome for the forearm, or what are the dermatomes for the front of the thigh, Google will tell you. You'll find these pictures. You'll be able to see like, oh, this falls in the distribution of L3. Maybe my problem in my leg is not due to a muscle pull or a muscle tightness in my leg. Maybe it's actually tight and achy because the spinal nerve root is irritated. So you can look up these things for yourself and start to consider if it may be part of your problem, but it really is on the burden, or it is the burden of the clinician to understand these concepts and apply them to diagnosing and therefore choosing the effective match treatment. These maps are not tried and true 100%. There is some individual variation where specific nerve roots travel in the body, but they are for the large part something we can really rely on. So I encourage you, especially if you have symptoms that are not resolving, to consider checking out a map of dermatomes and trying to understand if maybe the problem is actually in the spine.